Good afternoon. Thank you for having me today. Um, Factors related to underdiagnosing of breast cancer include imaging, lesions or patient-related or radiologist-related. On imaging, to ensure an ideal MLO view, breast should be pulled out with nipple in profile. The pectoralis muscle margin should be well visualized. The lower edge of pectoralis muscle should be at the level of pectoralis nipple line. Pectoralis nipple distance should not exceed 1 centimeter of the same measurement of the MLO view to avoid missing deeply seated lesions. On imaging, when MLO image of both breasts are viewed as mirror images, pectoralis muscle should meet in the midline and form the shape of a V. Can you spot the mistakes? In image A, nipple is not in profile. In B, pectoralis muscle is not visualized. In C, edge of the pectoralis muscle is not well defined. While in D, the lower edge of pectoralis is above the pectoralis nipple line. In E image, inadequate coverage of lower quadrant. In F, inframammary fold is not visualized. In such case, it's a vicious cycle. Is it a rolled-in nipple or a retroareolar lesion? Which one do you think? Case 1 is the retroareolar lesion, as by ultrasound it shows the lesion. However, in case 2, it was a slightly inverted nipple. Dense breasts. The breasts are divided into A, B, C, and D categories according to their densities. A is almost all fatty tissue. B, scattered fibroglandular densities. C, mixed fatty and dense but heterogeneously dense that may obscure small lesions. In D, they are extremely dense tissue. Complementary studies for dense breasts include 3D tomosynthesis, which cuts the breast into thin slices, so if there are any speculated lesions underlying the dense adenotic parenchyma, they will be visualized. What if tomosynthesis is not available at your facility? Compression view is an alternative. What if compression is not available? Rolling view is the view of choice, either rolling medially or laterally. For example, in such case, in left CC, there was a suspicious area of parenchymal distortion. After left CC rolling view, it appeared as summation of parenchyma, no suspicious findings. Proper patient positioning during ultrasound examination is mandatory to ensure a conclusive ultrasound examination. Patient should be lying comfortably, ipsilateral arm abducted and raised above her head to thoroughly evaluate the axilla, then lying on her side to examine the outer quadrants. In supine position, to examine the inner quadrants and inframammary fold. You should not miss scanning the hidden areas, which include infraclavicular region, axilla and axillary tail, parasternal area, and inframammary fold, which may be missed by mammogram. Carefully examining the axilla is mandatory, as in many cases, the mass might be located in axillary tail. It might not appear in the CC view. Therefore, proper interpretation of the MLO view and proper evaluation by ultrasound is very important. Pathological axillary lymph nodes might be the only finding, while no suspicious masses are found in the breast. Therefore, further studies might be recommended. Lesions-related factors include the size of the mass or the breast. Small malignant lesions in dense adenotic or large breasts are easily missed. Therefore, careful ultrasound examination is required, as well as additional studies as 3D tomosynthesis or contrast-enhanced mammography in some cases. The type of breast cancer is related also to the factors of underdiagnosis, as invasive lobular carcinoma manifests as areas of parenchymal distortion rather than sizable masses, as shown in the mammogram. BI-RADS 3 masses in such cases, like newly reported in age above 40 years, first presentation, no previous studies for comparison, or newly developed above 40, were not there before in comparison to previous studies, or increase in size or changes in morphology. A finding can be upgraded to BI-RADS 4 or 5, or downgraded to BI-RADS 2 at any point along the follow-up. In the end, it comes down to the radiologist's interpretation of the findings. Therefore, true-cut biopsy is recommended in the previously mentioned cases to exclude atypical features and benign-looking carcinomas. Also, asymmetries, either focal asymmetry or single-view asymmetry. Often, they are interspersed with fat, with or without calcifications or architectural distortion. They are classified as benign if detected on initial screening with no associated calcifications or distortion. However, biopsy is recommended if they are newly developed or increasing in size or density, as there is a chance of malignancy of more than 12%. BI-RADS 3 findings on mammography include also a solitary group of round or punctate calcifications. However, they might be benign in nature, like in fat necrosis or post-surgical scar. On follow-up, if they change in number or morphology, biopsy should be recommended. Excuse my voice, I had bronchitis and I didn't recover yet. A well-circumscribed, non-calcified solitary mass, if circumscribed margin is less than 75%, further evaluation is recommended. If interval growth occurs, biopsy should be done. If morphological changes occur on follow-up biopsy, true-cut biopsy should be recommended. In this case, interval increase in size occurred in an apparently benign mass after 2 years. After true-cut biopsy was done, it revealed a mucinous carcinoma. Patient-related factors include large breasts. Therefore, meticulous examination and proper positioning should be done. In cooperative patients or patients on wheelchair, overwhelmed or over-worried patients, you should explain the examination to your patient and try to reassure her before starting your scan to make it an easier experience for both of you. Radiologist-related factors include history taking. It is extremely important, as positive family history of breast or ovarian cancer, previously breast surgeries as lumpectomies, fat injection, or breast augmentation, as sometimes you might find an area of parenchymal distortion or an ill-defined mass. After thorough history taking from the patient, you discover she had done fat injection before and they appear as fat necrosis on ultrasound. You might put her on follow-up. However, you should not miss such important history tip. Hormonal use or IVF, her menstrual cycle, either it is irregular or regular. Previous studies to compare to, as it might solve the clue if you have an asymmetry in her mammography, if she has earlier or previous studies to be compared to, you might put her on BI-RADS 2 if they are stationary, or you might put her on BI-RADS 3 for follow-up if they are not stationary or there are no previous studies to compare to. Regarding her complaint, her onset and duration, inspect for any pathology as inverted nipple erosions or inverted nipple or skin nodules. Avoid happy eye syndrome, which is seeing one answer to a problem. It might make you less likely to look for another, which might be less obvious one, but more suspicious and significant. You should give the normal side as much attention as you do with the abnormal one, because breast cancer can occur bilaterally or even with a second primary in the contralateral side, which makes a huge difference in the patient's management. Please avoid distractors like mobile phones, phone calls, or side talks, noise during the work environment while interpreting the mammography, comparing it to previous study, and examining your patient with ultrasound. When in doubt, refer to your senior or other colleagues, because 2 pairs of eyes are always better than 1. Thank you, and see you next time.
Thank you, Professor Yasmin, for your nice presentation. And now breast imaging